Welcome to our channel, Your Health Pillar. Our aim is to provide to our viewer a general information on this subject. However, each patient's condition is different, either due to the disease itself or the patient comorbidity. So you should consult your specialist doctor, or you can contact us and refer to our doctors who are specialized in this area. This presentation also may contain some clinical pictures or even operative videos. Viewer discretion is advised. If the viewer is very sensitive to this content, please avoid watching this graphic content. In this video, we're going to talk about several keyhole surgical repair techniques for ventral abdominal wall hernias. These include umbilical hernia, epigastric hernia, incisional hernia, lumbar hernia, and spigellian hernia, which come through our rectus muscles. So what is hernias? Hernias refer to the defect in the underlying muscle and fascia. So there's a hole there in our abdominal wall, allowing the internal organ to protrude out underneath the skin. So the patient may notice a lump there during straining or standing, and the lump may disappear upon lying down. And sometimes the lump can stuck there due to the incarceration of underlying substance like PrePeritoneal fat or the small bowel. In worst case, it can cause strangulation of small bowel, leading to gangrenous of the small bowels. Incisional hernia refer to the state where the patient had previous open surgery, open abdominal wall surgery, and after the wound healed, for some reason the underlying fascia and muscle break down, leading to a defect and leading to the hernia to develop. These patients with previous open abdominal surgery has higher risk to develop incisional hernia if they have a wound infection after the surgery. These clinical pictures illustrate different stages of umbilical hernia. For the very early stage, on the left upper corner marked out by yellow frame, sometimes the patient may not even notice they have umbilical hernia until they have pain. The symptoms usually arise due to the trapping of underlying fat, because beneath our umbilicus there's usually some fat pad, and the first things that come through the umbilical hernia is this fat pad. When the umbilical hernia getting bigger and bigger, obviously the small bowel can go through and trap inside the umbilical hernia. And in worst case, it can get strangulation and even gangrenous of the small bowel. However, the chance is not high. But when the umbilical hernia getting bigger and bigger, as illustrated in the lower two pictures, sometimes due to constant frictions of the overlying skin, the skin may even start to change color or ulcerated. Ventral abdominal wall hernias have many different repair techniques, from the old days open repair, primary suture of the defect, to nowadays keyhole repair, laparoscopic repair, even robotic surgery. And it is generally agreed that using synthetic mesh repair can achieve the best outcome. There are many different operative repair techniques for ventral abdominal hernias, from the old days open repair to nowadays keyhole repair. Open repair means that we use open abdominal wound to repair the hernia defect, either with mesh or without mesh. Because of the larger size of the wound, the postoperative pains may be higher for these patients, and also the risk of wound infection is higher. Infection is one of the major concerns, especially when we're going to use mesh to repair, because foreign body, if the bacteria involve the foreign body, the infection will be very difficult to eradicate with antibiotics. Keyhole repair, on the other hand, the keyhole size range from 5 mm to 10 mm or even 12 mm, depending on the size of the mesh that we want to use. It becomes a major breakthrough because we can place a large size mesh through a keyhole into the abdominal cavity to repair the hernia defect. And because of the size of the wound is very small, the risk of wound infection is much lower, and it can achieve a much better long-term outcome. In these videos, we are mainly talking about keyhole surgery repair, laparoscopic repair for ventral abdominal wall, the development. It was developed first in 1990s, so almost 20 to 30 years ago. And initially, we placed the mesh within the abdominal cavity, peritoneal cavity, so the mesh will be in contact with our small bowel and large bowel. It is placed behind our abdominal wall. However, over the years, we have seen problems with this technique because the mesh is a foreign body. Although all these mesh are coated, specially coated with material, try to prevent reaction of this mesh to our small bowel and large bowel. We still see some cases come back to the hospital with intestinal obstructions or even the mesh erode into small bowel and large bowel due to chronic foreign body reactions. In view of this, in the last 15 years, a lot of specialist hernia surgeons are trying to develop a new technique of keyhole surgery to place the mesh within the abdominal wall itself, because our abdominal wall have many different layers. It have a skin. Underneath the skin, there's a fat layer, and then the fascia, and then the muscle. The muscle is actually held within the muscle compartment by fascia. And finally, there's a peritoneum, very thin lining of the abdominal wall. Then it comes to our peritoneal cavity. So in the last 15 years, we are trying to develop different methods, try to place the mesh within the abdominal wall itself so that the patient can enjoy the long-term benefit of synthetic mesh repair without the risk of mesh reacting to the small bowel and large bowel. Showing in this diagram is the cross-section diagram anatomy of our abdominal wall. You can see on the top layer is actually our skin and subcutaneous fat, and below that is then our muscle and fascia. You can see the center is the two rectus muscle, the left and right rectus muscle in their own compartment. The compartment is made up of the muscle fascia, which is a very strong whitish material that provide a strong structural support of our abdominal wall. Laterally are the three layers of muscle, the external oblique and internal oblique, and then the transversus muscles. Below the muscle and the fascia then come the very thin peritoneum. This is a very thin lining, line up the whole peritoneal cavity. And within that cavity lies our small bowel and large bowel. The first laparoscopic surgery developed in 1990 is actually the IPOM. The technique placed the mesh behind the abdominal wall, behind the thin peritoneum, within the peritoneal cavity. So the mesh is actually coming into direct contact with the small bowel and large bowel. Because the synthetic mesh is actually made from polypropylene, which is plastic, or polyester, these two materials are not supposed to be in contact with our small bowel, because they will induce a chronic inflammation reaction and leading to adhesion or even fistulation or migration of the bowel erosion into the small bowel. So this material, these mesh are all coated with special material, including collagen or omega-3 oil or some other material by many different companies. They claim that this will reduce the reaction to our small bowel. However, over the years, like last 20 years, many surgeons find out that a lot of patients still develop adhesion, and some of them will present with adhesion-induced obstruction, or sometimes even the mesh may actually migrate into the small bowel, causing fistulation or erosion. That's why over the last 15 years, many specialist hernia surgeons are trying to develop techniques to place the mesh outside the abdominal wall cavity. So why do we use mesh at all? Because the mesh will provide very strong support and then occluding the hernia defect. This is to achieve a very good long-term result with very low recurrence rate. So mesh is actually good in repairing the hernia. However, it does have its own complication, like the one that I just said. So we are trying to develop techniques to place the mesh within the abdominal wall now, outside the peritoneal cavity. One of the techniques is actually between the peritoneum, thin peritoneum, and the muscle fascia, like the green layer you see here. This is called PrePeritoneal Onlay Mesh repair, PPOM, or sometimes people call it Ventral TAPP. The other layer is actually behind the muscle, which is more popular nowadays in America and Europe, which is what we call eTEP, or retrorectus technique. Sometimes if we need to extend the mesh laterally, then it's called lateral. So you can imagine for the red mesh to place behind the muscle, first of all, we need to cut the muscle fascia at the midline. So the linear elbow need to be incised. Okay, nowadays they don't actually incise the linear elbow, they cut the fascia below the linear elbow. So basically this involves a lot of alteration to your muscle and fascial compartment. So in this slide, we are basically refreshing what we just said. So the black one is the first keyhole surgery, the IPOM, Intraperitoneal Onlay Mesh repair, the mesh placed inside the peritoneal cavity. The red one and the green one is actually the newer technique that has been developed in the last 10 to 15 years, to place the mesh within our abdominal wall layers outside the peritoneal cavity so that we can enjoy the benefit of mesh repair but avoid the mesh-induced complication. So we're going to go into the 3 operations in details now. The first is IPOM, the first operation developed for keyhole approach in 1990s. This operation is technically very straightforward, and then it is quite straightforward to train the surgeon, and it is reproducible in many different centers. So this is still now one of the most commonly done operations to repair ventral abdominal wall hernia all over the world. The mesh is placed inside the peritoneal cavity. That's why the mesh needs to be specially coated, because it will come into direct contact with the small bowel and large bowel. To fix the mesh to the abdominal wall, the fixation needs to be very secure, because you don't want the mesh to fall down and mix with the small bowel in our cavity. Then it will end up with obstruction and strangulation of the bowel. The fixation usually is done by tacker, like a staple. The space between each staple has to be less than 1 centimeter apart, because if it's too far apart, there's too much space between the staples. Sometimes the bowel can slip in between the mesh and abdominal wall and got trapped there. Then you end up with bowel obstructions. Although this mesh are specially coated with supposedly organ-friendly material, however, because it's a foreign body, a lot of people still develop adhesion to the mesh. Whether they will present with clinical symptoms like bowel obstruction or pain depends on how bad that adhesion is. And there's no parameter to help to identify which patient is at risk of this possible complication before the operations. So we will no way to know who will run into trouble with this mesh, because basically we don't know who is going to have more reaction with the material or coating material, who will have less reactions. But these complications are difficult to manage. If you have a bowel obstruction going into the abdominal cavity to try to release the bowel obstructions, is very difficult, because there are going to be a lot of adhesions. So nowadays a lot of guidelines suggest that when you're using this method, the patient must be fully informed of the potential complication, and this technique should be used in caution. This diagram illustrates what IPOM is. So the mesh is placed within the peritoneal cavity, so this will come into direct contact with the small and large bowel. The mesh needs to be fixed securely behind the abdominal wall. So we use tacker, similar to staple, to fix it circumferentially surrounding the whole mesh. Each tacker needs to be less than 1 centimeter apart, because we can't leave too big a gap. Otherwise, the bowel can slip between the mesh and the abdominal wall, caught up there and causing bowel obstructions. What about the size of the mesh? Because it's a foreign body, after placing into our body, there will be scarring over the mesh. This will cause the mesh to shrink in size, sometimes between 30 to 50%, up to 50% in some studies. So basically, on each side of the defect, you need to have at least 3 or 5 centimeter overlap. So basically, if you have a defect of 1 centimeter diameter hole, you need to use the mesh at least 9 to 10 centimeter or 11 centimeters in size, because over the years, the size of the mesh may actually shrink down to just 5 centimeter or 4.5 centimeters. And if you use a too small a size, or the mesh is not fixed in the center after shrinkage, the defect may re-expose and causing recurrence. So you can see with that many tackers, the patient can actually experience a lot of pain after the surgery. So although this is a minimally invasive surgical technique, but the pain level is actually quite high after IPOM repair. On the diagram, on the left side, you can see the white mesh. The white color is the mesh. The pink color is the back of our abdominal cavity. This mesh is actually a Gore-Tex mesh, so this is a very heavy-duty thick mesh. So here comes one of the two newer techniques that developed within the last 15 years, the eTEP or retrorectus technique. So this is placing a mesh behind the muscle within the muscle compartment. So this have the benefit of placing the mesh outside the peritoneal cavity to avoid the visceral complications such as adhesion or fistulation to the bowel. But the problem is, in order to place the mesh within the muscle compartment, you need to connect the two rectus compartments. You remember the rectus, the left and the right rectus are each housed in its own room. So basically, we knock down the wall in between and connect the two rooms. So means that we need to cut the midline fascia in order to join the left and the right rectus space. And if this space is not great enough in order to extend laterally, we need to sacrifice one of the lateral abdominal wall muscles, which is the innermost layer. The transversus muscle need to be cut. I can illustrate that in the diagram later on. So this involves extensive alteration of the muscle and fascia architecture of the abdominal wall. And then there's this extensive tissue dissection because you need to connect the two rooms, the left and the right rectus compartment, from the epigastrium down all the way to the pelvis in order to place a mesh. This is technically very complex and require high level of training because sometimes you can get lost and dissect in the wrong layer with the muscles. It is an irreversible process. So if you have done this operation and there's a complication arise like breakdown of the posterior fascia on posterior layer, then it is very difficult to repair the complications. So it is an irreversible process. In this diagram, we illustrate what the retrorectus eTEP technique is. Basically, you place the mesh behind the muscle inside the muscle compartment. In order to do that, we need to cut the muscle fascia in the posterior part, basically the linear elbow, like shown in the red arrow here, from the epigastrium all the way to the pelvis. And after placing the mesh, this layer need to be closed. And sometimes because of the tissue loss during the cutting of the fascia, this repair is under tension and it can break down in some of the cases. In minority of the cases, if the posterior layer actually break down, it will be a nightmare or it will be a very difficult situation because it's very difficult to repair the whole things because the whole abdominal architecture has been altered. And the left and the right rectus compartments sometimes are not big enough. You remember we talked about the mesh size. If the mesh size is too small, the size of mesh to place in here is too small, it can actually shrink down and re-expose the holes. So if we need to use the larger mesh, or if when closing the posterior fascia is under a lot of tension, we need to release the tension, or if we need to use a larger mesh, we need to extend it laterally. There are two reasons for us to extend laterally. First of all, obviously, when we need to use a bigger mesh, either for a bigger size hernia, or because the right and the left rectus compartment, muscle compartment, is too small to house the desired mesh. Secondly, is when we close the midline, like here, the cut fascia and the peritoneum. When we close the midline, we find out there's a lot of tensions. In order to release the tension, we need to extend laterally. Because the fascia, the fibers actually running transversely in the same direction as the suture. So if there's too much tension, the suture can actually cut through and this layer can break down and re-expose the mesh. Certainly we don't want that to happen after the operations. To extend the laterally, we need to cut one of the three layers of our lateral abdominal wall muscles, namely the innermost layer, the transversus muscles. The technique is called TAR, Transversus Abdominis Release. This is originally designed for very complex and large-sized ventral abdominal hernia. Basically, it is doing a reconstruction of our abdominal wall architecture. After cutting the lateral muscles, then we can extend the mesh laterally and close the midline without tensions. As you can see, this is a very complex operations. The surgeon need to be well trained because in the muscle layer, there's a lot of neurovascular bundle, means the nerve and the blood vessels bundle. If these are injured, it can cause ischemic to our ventral abdominal wall. Also, now you see on the diagram, it's very clear. When you do the operation, dissecting in the muscle layer can sometimes be very difficult to know which layer you are dissecting. And people did get lost in this area and dissect in the wrong plane, causing a lot of muscle injury. Thirdly, this operation actually sacrificed one of the innermost layer of our lateral abdominal wall muscles. Remember, our abdominal wall muscles actually are very important. They help to protect our internal organs. Not only that, but they are the very strong support for our core and maintain our postures. And they are one of the major muscles in helping us for straining for urination or defecations, or sometimes even breathing as well. So when the patients get into their 80s or 90 years of age, when they have other underlying medical problem progressing, and will this technique further aggravate their problems? We actually don't know. But this is a very successful operation for treating major large-size complex ventral abdominal wall hernia, the LAPTAR. This is the second keyhole surgery technique developed in the last 15 years, the PPOM, TE-PPOM, or Ventral TAPP. This is a true preperitoneal mesh placement, which means the mesh is placed within the very thin peritoneal lining and the posterior muscle fascia. This is the second last layer of our abdominal wall. It does not involve any fascial cutting or muscle resections. This is the most natural way of placing the mesh outside the peritoneal cavity, and it can enjoy both the very good long-term result of mesh repair, but avoid the mesh-induced bowel complications. However, this is technically demanding, as the peritoneum layer is a very thin layer tissue covering our whole abdominal peritoneal cavity. This is the diagram showing the PPOM technique or ventral TAPP. So the mesh is placed in the second last layer. So it is between the thin peritoneum and the posterior fascia of the muscle. So the muscle and the fascia remain intact. No muscle fascia was cut and no muscle need to be sacrificed. We can actually place a very large mesh in this space because we can extend from the left to the right, even placing a 20-25 centimeter mesh or 30 centimeter mesh in this space. So technically, this is the most natural way to place the mesh outside the peritoneal cavity. So the bowel in the peritoneal cavity is not going to come into contact with the mesh, and then you can enjoy the secure long-term result of the mesh repair. Thank you for watching this episode on ventral abdominal hernia keyhole surgical repair techniques. Ventral abdominal wall hernia can be very complex, so please consult surgeons specialized in this area, or you can actually contact us and see our specialists for full assessment and opinion. If you want to know more about this subject and any other health-related subjects, or you want to contact us, please log on to our web-based app, https://yourhealthpillar.com, or scan this QR code. Once you arrive in this page, on the left upper corner, you can click onto that and it will have instructions telling you how to install on your phone for easy access. This is a free app, allow you to have access to a lot of health related information, and also allow you to contact us for any health related issues, or you want to seek for specialist consultations. We will refer you to appropriate specialists for a full assessment. This app will not collect any personal information. Thank you all for your support.